Hello everyone, today we'll be discussing diabetic foot or diabetic foot ulcers. The prevalence of diabetes mellitus is rapidly spreading at an alarming rate worldwide. Diabetes mellitus is known to damage multiple organs including the heart, kidney, eye, and nerves, leading to complications such as heart attack, stroke, blindness, kidney failure, and lower limb amputation. Diabetic foot ulcer is a frequent complication that occurs in approximately 6.3% of patients with diabetes mellitus globally. The high incidence of diabetic foot ulcer and the associated mortality and morbidity are the most common reasons for hospitalization of diabetic patients. Early in the course of diabetes mellitus, patients experience serious food sensitivity symptoms such as pain and tingling, while later stages of the disease course are characterized by negative symptoms such as numbness and weakness of the toes. With the progression of the disease, patients usually show mixed pain sensitivity along with decreased limb sensation and motor function, which leads to imbalance and unsteadiness and increase the likelihood of falls. In addition, because of the increasing morbidity, diabetic foot ulcer is a leading cause of non-traumatic amputation and is associated with an increased risk of death. The pathophysiology of diabetic foot ulcer. So we need to know that diabetic foot ulcer comprises a full thickness wound that involves the dermis, located in the weight-bearing or exposed area below the ankle. The Wagner system aids in categorizing the severity of the ulcer, ranking it on a scale of 1 to 5. The pathologic mechanisms of diabetic foot ulcer are described in terms of a triad. The triad includes neuropathy, vascular insufficiency, and secondary infection due to trauma of the foot. So, when we talk about the pathophysiology, first, the lack of protective sensation in the feet predisposes patients with diabetes to developing trauma and ulcers. This sensory impairment occurs due to hyperglycemia. In addition to sensory neuropathy, diabetes can induce neuronal autonomic dysfunction that results in impaired sweat production, leaving the foot susceptible to dryness, skin cracking, and fissuring. Furthermore, motor neuron dysfunction can give rise to muscle wasting and structural abnormalities of the foot. This causes focally elevated pressure at various zones of the plantar foot and increases the risk of ulceration. In addition, In addition to the triad, impaired wound healing has been established as a key means of diabetic foot ulcer progression. Along with inflammation, substantial alterations of the extracellular matrix also play a significant role in perpetuating the non-healing diabetic foot ulcer. So, in cases of normal wound healing, the production and degradation of extracellular matrix proteins such as collagen and fibrin are tightly regulated. Collagen comprises most of the soft tissue extracellular matrix, and thus abnormalities of collagen metabolism have significant consequences on wound healing. Specifically, collagen degrading enzymes known as matrix metalloproteinases (MMPs) become hyperactive, resulting in a highly proteolytic environment with reduced collagen content. Overall, the extracellular matrix becomes disorganized and insufficient to support wound healing. Lastly, impaired angiogenesis plays a key role in the disruption of diabetic wound healing. Angiogenesis ordinarily occurs during the proliferative phase of wound healing and is responsible for both the formation of granulation tissue and delivery of nutrition and oxygen to the wound. So, when this impaired angiogenesis in diabetic foot or in a patient with diabetes, so the above functions will not occur. So that will lead to disruption of the wound healing process. So when we look at this short table, we'll notice we talk about the triad, which was neuropathy, vascular insufficiency, and secondary infection. So because of the neuropathy, there's sensory loss, motor neuron dysfunction, and autonomic dysfunction. Then due to the vascular insufficiency, there's inadequate blood flow, which leads to ischemia and impaired wound healing. Then, due to the secondary infection, which is usually due to trauma, there's inflammation, impaired wound healing, and reduced angiogenesis. So, all the three factors come together, leading to diabetic foot ulceration. So, let's look at the Wagner classification. So, it starts from 0 to 5. So, stage 0 is the pre-ulcerative area without an open lesion, as you can see on the first diagram. Then grade 1 is a superficial ulcer, which may be partial or full thickness. Then 2 is ulcer creeps to the tendon, capsule, or bone, so that's a deep ulcer. Then stage 3 is stage 2 with abscess, osteomyelitis, or joint sepsis. Then grade 4 is localized gangrene or partial gangrene of the foot. Then stage 5 is a global foot gangrene, whereby the gangrene affects the whole foot. So when we look at management of diabetic foot ulcer, there's preventive care, there's non-invasive modalities and invasive modalities. So on preventive care, you need to teach the patient self-screening, healthcare screening, using of insoles, and podiatric care, which is foot care. Then non-invasive modalities include wound dressing, total contact casting, hyperbaric oxygen therapy, topical growth factors, shockwave therapy, stem cell therapy, use of antibiotics, wound care, megotherapy. Then invasive modalities include debridement, revascularization, skin grafting, and amputation. So that's all about diabetic foot ulcer. Thank you.